Hello everyone, this is Dr. Maurice Skillen coming to you from the Physician Associate Interdisciplinary Clinic. I just wanted to get on here and recap my week, to talk about some things I've seen this week. To start with, I had the privilege of taking care of about 10 veterans this week, of which I did CMP exams on through telehealth, as I mentioned in a prior video. And I wanted to get on here and cover a few, or at least one subject that I've seen this week, prior to this week, and I see it habitually happening as I do the CMP exams. It's not anything negative against the VA. It's not anything negative against the veterans, but it is something that needs to be addressed. What I find mostly when I'm doing CMP exams is the lack of knowledge that has been shared with the veterans in reference to putting in paperwork or what they need to do to file a claim. These are issues that should be addressed, but for some reason they are not addressed sufficiently enough. While I'm doing CMP exams with veterans, I'm not at liberty to discuss such issues with them because the CMP exam is not for that purpose. There's no treatment involved. It's a physical exam that of which I'm taking measurements and documenting objective findings to submit the documentation to the VA so that their claim can be evaluated and a judicious decision can be made. And I'll be the first to tell you that I have no control over the process beyond doing an excellent physical exam and asking key questions that'll generate me the information that I can incorporate into the physical exam or in the DBQ documentation to afford the veteran the appropriate evaluation material so that a judicious opinion can be given on their claim for service. What I'm finding is that there's significant lack of sharing of knowledge with veterans in reference to any surgical procedures they may have. When I'm evaluating veterans, I'm finding that while they know that and sometimes that they can file a claim for whatever the condition was that caused the need of the surgery, they're not aware that if they have any post-surgical complications, they can file for those conditions also. And this is just knowledge that has not been shared with them that I come across in the process of asking them questions in reference to both the condition that necessitated the surgery as well as the post-surgical complications that arise after the surgery. And it's through those conversations that I've been able to ferret out further information that needs to be documented in reference to that whole process. There's another key element of the surgical process that I don't think veterans are given the information for also. If you veterans are given any type of surgery for a condition, if you're left with a significant scar on a part of your body, whether it's exposed on the face, hands, legs, or feet where they can be easily seen, or whether they're not exposed in areas such as your abdomen, chest, back, or something like that. If there is a surgical scar there and you're having problems with it, which could include discomfort to palpation or irritation when wearing outer garments, these are things that can be complication post-surgical with the remaining scar. And of that area, when I'm talking to veterans about surgeries, I find that I am frequently adding the scar DBQ to the surgeries because the veteran has no knowledge that they should be filing for the scars also. And it's through this lack of knowledge that they're not filing for that particular complication, which is post-surgical. And I've had the privilege of taking care of many veterans who have had surgeries 5, 10, 15, 20 years ago who have significant scars, whether it be on their abdomen, their total knee joint, their shoulders, their faces, or their heads, or their back, buttocks, or any other anatomical area that have a significant scar that they haven't filed for. And in conversating with them, I find that a lot of these scars are causing issues for them, whether it's if they have a scar somewhere on the face, if they try to wear something such as glasses or something of that nature, that the scar is becoming irritated, whether it's the scar on the abdomen that's irritated by wearing a belt or wearing tight clothing, which forces them to have to wear loose clothing to stop from irritating the area. These are significant post-surgical complications that a veteran may have that they can file for that they have not been educated on. And it's unfortunate. Me, myself, in the process of doing CMP exams, one of the questions that's directly in the DBQ that is covering the area that I might be evaluating them for is a question that asks specifically, does the veterans have any scars or disfigurements secondary to any surgical procedures that were done to correct whatever abnormality that the veteran may have had done while on active duty? If I answer yes after talking to the veteran, it automatically can open up or allow me to create another DBQ that will cover that scar that the veterans have not filed for or been given knowledge that they should file for, okay? Even with that, I cannot give you an absolute certainty that service connection will be granted for the scar, but I implore every veteran I talk to, and again, if I'm doing a DBQ, I'm gonna ask that question. And if the veteran tells me that the scar is uncomfortable or causing any type of discomfort, then I know to automatically click that area that's embedded in a DBQ, which will automatically open up the scar DBQ, disability questionnaire, from which I can document the scar as well as document the problems that the veteran may be having with that scar. These are important issues that need to be addressed. They're post-surgical issues. And like I said, most veterans aren't aware that they can or should file for such post-surgical complications following the surgery, as well as filing for any post-surgical complications that may arise from the surgery that was performed in general, as well as submitting a claim for the reason that the surgery was done initially for. Another issue I'm finding frequently as I'm dealing with the subject matter is the fact that sometimes the surgeries are done for congenital abnormalities, congenital being abnormalities that the soldier or veteran may have when they're born, that they had before they entered the military. This is a fact that is proven by whatever condition it is. If it's known in the medical literature as a congenital abnormality, then by right of the veteran having that complication or that disease process prior to entering service, they cannot claim that particular injury or congenital abnormality as a direct service connection. Because as I said, such congenital abnormalities existed before the veteran entered the military. Thus, that would preclude them filing for a direct service connection. And this is where I've got to tie in what I was talking about initially, which is if surgery is done on even that congenital abnormality, okay? Let me repeat that. If a veteran has a congenital abnormality that's not documented when they come in, that through the surgical literature is known as a congenital abnormality before they enter service, you can't file for a direct service connection for that condition. But you can file for aggravation of the condition if it's aggravated during your time in service as a veteran. And what that means is that the congenital abnormality through service was aggravated beyond its normal course by the service, which is demonstrated by the veteran going in and being seen for that congenital abnormality while they're in service. Now let me bring everything back around to what I talked about initially, which involves also the congenital abnormality that may exist. Veterans are being told that if they have a congenital abnormality prior to entering service, which again is known through the medical literature as a congenital abnormality prior to service, while they cannot claim direct service connection for it, and while they can claim aggravation of the area through service, there's another disposition they can claim for that particular congenital abnormality, even if it existed prior to entering service. And that would include if any surgery is done on that congenital abnormality while the veteran is in service, okay? If surgery is done on it, again, they still cannot claim a direct service connection for the congenital abnormality in and of itself because it existed prior to service. But what they can claim is any post-surgical complications done from that surgery to correct that congenital abnormality, which in gist means that a service connected or service involved surgeon, whether it's done by a military surgeon or if you're consulted out to a civilian service surgeon to do that surgery on that congenital abnormality, when the surgery is done, okay, it was a recommended surgery for a congenital abnormality that pre-existed, but the veteran may have had problems significant enough of that injury or congenital abnormality that led the surgeons, again, whether military or consulted out to a civilian surgeon for that surgery. Once the surgery is performed, the surgery in and of itself takes the congenital abnormality beyond its normal course, secondary to the surgery being done. In this instance, it is my opinion that that congenital abnormality was taken beyond its normal course, and common sense would kind of create the situation that even though it was a congenital abnormality that existed prior to surgery, once surgery is done on that congenital abnormality while the veterans are in service, again, it takes whatever that congenital abnormality that if it was not touched or aggravated through service, it would have remained a congenital abnormality that had no abnormalities, or it wasn't aggravated beyond service. But again, once surgery is done on that congenital abnormality during service to correct whatever complications or complaints the veteran may have had during service for that congenital abnormality, once service is done, again, it theoretically and in most cases takes it beyond its normal progression, which means that if the veteran would have never had entered service, the congenital abnormality may never have been noted, and the veteran may never have complained about the congenital abnormality if they were outside of service. But in this instance, because the veteran complained of complications of that congenital abnormality in service, were evaluated by a military surgeon or consulted out to a civilian surgeon to address the complaints the veteran may have of that congenital abnormality, whatever treatment, surgical or otherwise, that are done to that pre-existing congenital abnormality brings it into play as a potential service-connected abnormality that was taken beyond its normal course by the surgery or the treatment itself. And thus, the veteran theoretically should have the ability to file for that congenital abnormality that they received treatment for or surgery for while on active duty that took the congenital abnormality beyond its normal course. It just plainly makes sense if you stop and think about what I just said. And to add to that, in my research for such conditions, I have found where the VA, through relooking or adjudication of the denial, which is the veteran puts in a disagreement of the finding within a year of receiving that denial of service connection is called a notice of disagreement. If the veteran files that within a year of that denial, then that case stays open, which will leave room for further argument or further discussion on that particular condition. If a veteran does not file a notice of disagreement within a year, that case will be closed and it will not be able to be reopened without new information being submitted about that particular injury. But as I said, in my research, I have found where the Veterans Administration, through adjudication, through a judge, after they file a notice of disability, where the VA has found in favor of the veteran, using the common sense or using the thought out process of the veteran entered service with a congenital abnormality that was not known because it was such a congenital abnormality that would necessarily come into play unless the veteran had symptoms caused by that or of that congenital abnormality. If they have such symptoms at that point, they will, because they're active duty, be evaluated for those symptoms. And even though it may have existed prior to service, any treatment or surgery done to that congenital abnormality brings it into play for service connection. And I'm not saying that because Dr. Skillen says so. I'm saying that because it just basically makes medical sense. I found such things in the medical literature, and again, I found where the VA, Veterans Administration, through adjudication beyond the denial because it was a congenital abnormality, where the Veterans Administration has ruled more than any one time in favor of the veteran and allowed service connection of that congenital abnormality based on the fact that with any surgery or treatment, that congenital abnormality that existed prior to service was taken beyond its normal course of progression if the veteran would not have been in service, which could cause symptoms of that congenital abnormality, which in effect take it beyond its normal course by service, or it was taken beyond its normal course secondary to any surgical intervention of the condition. Let me give you a for instance of this. If a veteran had symptoms of shoulder discomfort, okay, while in service, while that veteran is being evaluated for that shoulder discomfort that may stop them from being able to perform their job while in service, which may cause them to go on sick call, which may cause them to be consulted to the orthopedic clinic. If the orthopedic clinic doctors, who are usually surgeons, find a congenital abnormality of the shoulder that they find is aggravated at that time, okay? So it's a congenital abnormality that's found through evaluation that is apparently been aggravated by service, whereas they were sent for evaluation to an orthopedic surgeon for the shoulder again, as I was saying, okay? If that congenital abnormality through treatment is not resolved or calmed down to a point where the veteran can move forward without needing any further treatment, then again, they may have had one symptom or one period of symptomology from that shoulder, which does not create a pattern that shows that they have a consistent chronic injury or aggravation, again, of that pre-existing congenital abnormality of the shoulder, and they had no further treatment. At that point, that doesn't show a chronicity of the irritation of the congenital abnormality, which would create then a secondary ability for the veteran to file for that congenital abnormality because it was aggravated by service, okay? And what that would call for is that the veteran would need to be seen several times during service for that congenital abnormality. If that be the case, if they file for service connection for that shoulder that is a congenital abnormality, if they file for it post service, once they leave the military, then because of service and because chronicity of that injury to the congenital abnormality caused by service will allow them to get service connection, because due to service, whatever their job may be, whether it's painting trucks or what I did in the military, which is as a PA, their job function aggravated whatever that congenital abnormality was that was noted during surgery, and they were seen and treated for consistently, would create a chronicity of that congenital abnormality, which would allow a veteran to file for service connection, again, for that congenital abnormality, based on it being irritated by service, which, and I hope I'm not being too technical, but what that will do is it will alter the normal course of progression of that shoulder injury, which is a congenital abnormality, beyond its normal course, which creates a situation that would open the door for potentially the veteran getting service connected for that shoulder injury, even though it's a congenital abnormality, based on the fact that service, whatever they were doing, injured that congenital abnormality, causing them to go to be seen on sick call and or being consulted to an orthopedic surgeon who evaluates that congenital abnormality and treats it. Initially, they're going to try conservative treatment, which may be NSAIDs, ibuprofen, naproxen, or some other NSAID, maybe a COX-2 inhibitor that might not cause as much duress or stomach duress or gastrointestinal issues if they take it, if they're seen once for that, and that discomfort or whatever the complication of that congenital abnormality is resolved with one trip, then no, the veteran cannot, in effect, or I'm just saying, this is my opinion, the veteran had one situation of the shoulder discomfort that aggravated the congenital abnormality that was resolved with one treatment. And what I mean by that is that by that one intervention, even though it may be by the orthopedic surgeon, does not demonstrate a chronicity of a problem with that congenital abnormality aggravated by duty, which would open the door or create a nexus to demonstrate a chronicity of that shoulder discomfort that was noted on active duty, aggravated by whatever the soldier's duty was to that congenital abnormality, okay? If they're seen for it a couple of times during service, or they file a claim, or they go to be seen for it by the VA within a year of leaving service, and I mean within a year of leaving service, then they should be able to file for chronic irritation demonstrated by multiple sick call or multiple orthopedic consults to be seen by that, and or if they're seen within a year of leaving service for that shoulder injury and it's found to be significant, within that realm, they can file for service connection for that shoulder. And by the regulation and by my view, I also worked for the VA back in the day. By my view or by my experience, has demonstrated that that would create a chronicity of the shoulder injury that takes it beyond its normal course of progression, which should allow the veteran to file for that service connection for that shoulder injury. Remember, we're still talking about the shoulder injury, okay? And I pray I'm not being too technical. But if so, just watch this video a couple of times and you'll get it. Or reach out to me through my clinic, shoot me an email. The information will be available for you. And it'll take me about 5 seconds to answer that question. I'll email you right back, or within a week, I'll email you back, giving maybe some advice on it, okay? As long as I am not your provider and I'm operating through my clinic, that won't cause a problem, okay? But again, getting back on the congenital abnormality of the shoulder that's aggravated during service. There's some more I need to talk about that congenital abnormality that may be aggravated during service, for which the veteran was seen multiple times on sick call for and or consulted to orthopedics to see an orthopedic surgeon or PA multiple times while on active duty and receive treatment for it. Again, that would create a chronicity of aggravation of that congenital injury that would allow or should allow for the veteran to file for service connection. Now we're going to take it a little bit further. If the veteran who may have had that congenital abnormality of the shoulder before they entered service is sent on sick call or consulted from sick call to see the orthopedic surgeon, and the orthopedic surgeon evaluates them, and after using conservative treatment and maybe some steroid injections or other treatment that's less invasive than surgery, if that does not calm that injury down to a state where the veteran can continue duty without further treatment, then unless there has been a chronicity demonstrated by repeated visits, then a veteran can't claim for it. But let's give it for instance. If that veteran is sent to the orthopod, they try conservative treatment, which is oral medication, whether it's NSAID, which would be ibuprofen or naproxen, or a COX-2 inhibitor, which is known to have less effect on the stomach, which ibuprofen and naproxen can cause if taken on an empty stomach, okay? If they try conservative treatment and that's not effective, non-invasive, and they move on to a shoulder injection with maybe steroids, and that is not effective, and the orthopedic surgeon, again, whether they are active duty orthopedic surgeons, which are great. I've had opportunity to work with plenty of those, both in uniform and out of uniform, and they're great, okay? If that surgeon, whether again inside the military, is in uniform or outside the military, you were consulted outside the military while active duty to see an orthopedic surgeon, and that orthopedic surgeon, after you fail conservative treatment and after you fail maybe steroid injections to the shoulder for that aggravated congenital abnormality, if they decide at that point that because it wasn't resolved with maybe non-invasive conservative treatment or with steroid injections, okay? Now let me throw in a caveat for the steroid injections before I move on to surgery. And I'm just trying to cover all these issues because all of these, for instance, I've run into while doing CMP exams in uniform, out of uniform, at the VA. I've run into these. If a soldier is in, again, for that congenital abnormality, they go to the orthopedic surgeon, and the orthopedic surgeon sets them up where they can come in and get the steroid shot, which is found to be effective. Most orthopedic surgeons won't do them before maybe once every 3 to 4 months. In my thought process, I have pretty much kept it to about every 4 months consistently. And whereas there have not been studies that show maybe any serious detrimental effects of doing it sooner than that, most orthopedic surgeons that I've had the pleasure of working with won't do it any sooner than maybe 3 to 4 months. And it's through them. If I'm seeing you as a orthopedic PA, which that's my specialty, and that's why I chose the shoulder. If I'm seeing you for that condition and I initiate the steroid injections of the shoulder, and if that is found to calm the area down, even though it's a congenital abnormality that's been aggravated by service, if I'm doing those every 4 months on you while you're in service to calm this area down, that in itself can create a chronicity that will allow the veteran to file a service-connected claim for that shoulder, even though it's congenital, because it needed the steroid injections every 4 months. to calm it down so the veteran can continue service in whatever profession they were doing, okay? These areas are usually aggravated in service by our high-speed infantrymen who might have to wear rucksacks on their back consistently, and there are other conditions that can arise from that, or other jobs. Maybe they're a mechanic constantly having to raise their arms above their head to do their job, whether it's on a vehicle, on an airplane, or anything. Those things, because it is a repetitive motion, can aggravate a shoulder, whether it's congenital condition that existed prior to service or whether it's not a congenital abnormality prior to service. If it's there, you come see me in the orthopedic clinic as a physician assistant, or if you see the orthopedic surgeon directly and they decide either or that steroid injections are called for after conservative treatment fails, and they initiate that process. And even if it works, where you can get the injection every 4 months, once a year, whatever it takes to calm that area down so you can continue performing your duties, that again would create a chronicity of that shoulder problem, that even though it is a congenital abnormality that theoretically by the medical literature existed prior to you entering service, because you needed such consistent intervention of that shoulder injury aggravated by service, even though it was a congenital abnormality, though you needed consistent or repetitive intervention to calm it down, that creates a chronicity of that area, which would or could or should, in my experience, allow the veteran to file for service connection, because in performing their duties in and of themselves, aggravated that congenital abnormality of the shoulder beyond its normal course, secondary to their duty MOS or their job, okay? And that creates, again, a situation where their duty aggravated their congenital abnormality beyond its normal course or progression. If they never would have been in the military and done whatever duties they were doing that aggravated, again, that congenital abnormality, the fact that in their duties, that area was aggravated to perform their duties, whether, again, mechanic, infantryman, whatever you may do, whatever job you do, and remember this, it's important. I don't care if you are working on trucks or whether you do what I do, it's important. If in performing your function, it aggravates that congenital abnormality, it should create an opening, especially if you're getting injections for it consistently while on active duty. It should create an opening where you can file for service connection for that congenital abnormality, because you needed consistent intervention, medical intervention of that area while you were in service performing your duty to allow you to perform your duty. Now let's take a few steps forward. If conservative treatment of that congenital shoulder abnormality, if conservative treatment doesn't work, if injections doesn't work, and if surgery is decided the next level that is needed for that veteran to try to resolve this problem, which by now is really aggravating the veteran while they're trying to perform their duties. And I will tell you this, that kind of aggravation can just be not good, or it can take your focus away from what you need to be doing. And if you're an infantryman or something like that, or even if you're working as a mechanic or as a cook or as a mail person, it can take your attention off what you're doing and cause a further injury, okay? So I want to stress that point. But again, I don't want to stray too far from what I'm talking about. If surgery is decided to be the next course of action for that shoulder, which is a congenital abnormality, I was aggravated by service, conservative treatment, and steroid injections did not work, and surgery is decided to be the next course, okay? Once that surgery is done, the surgery in and of itself, from my experience and from decisions I've seen or been able to research that have been made by the Veterans Administration, that surgery takes that area, which shoulder injury, which was a congenital abnormality that existed prior to service, it takes it beyond its normal course, okay? The surgery in itself. That means that because the surgery was needed, it takes that area beyond its normal course, and if the veteran continues to have problems for that shoulder or has any post-surgical complications secondary to that surgery, which could be chronic consistent shoulder pain that's unrelieved, then that creates that opening for the veteran to file for service connection for that shoulder injury that was a congenital abnormality that existed prior to service. It allows the veteran, or should, by my experience and what I've been able to research, should allow the veteran to serve for service connection for that shoulder, even though it was a conservative abnormality. As I said, the surgery in and of itself, which was decided by a surgeon after conservative treatment and after maybe steroid injection to the shoulder, have failed. If surgery is decided to be the next course of action, if you have the surgery in itself takes it beyond its normal course and should create a situation where the veteran should be able to file, and from my experience, allow them to be service connected for that shoulder, okay? Now, we talked about surgery. Let me go back into one other issue, because I feel it's important that even the veterans should know. And, you know, during CMP exam, I'm not able to talk to veterans about these issues because the CMP exam is not treatment. It's not discussing of treatment. It's me doing a focus exam on the area affected and gathering information, documenting it, to include pictures if needed, and sending that back off to the VA where they make all those decisions. But again, once the surgery is done on that shoulder, it takes it beyond its normal course. So if any veteran has had that kind of situation, as I've explained, and I hope I have not been too tedious about it, but these are particular issues that a lot of veterans I've talked to have not had knowledge of, and unfortunately they have not filed for these conditions because they didn't think they were able to do it, or they were told it was a congenital abnormality. Again, once surgery or consistent treatment is done to that area, service obviously is taking it beyond its normal course, which should open the door and allow that veteran to file for service connection. Okay, let's go further, and I want to cover this because sometimes I've seen where veterans have had a shoulder injury, okay, where they've fallen or been hit, or might have been a training accident, or it might have been an accident while they were performing their duties that may create an opening so that the shoulder may start becoming dislocated, okay? If that has happened on active duty and you had such an injury, and there's a chronic dislocation, okay? If initially they'll try conservative treatment. Again, we're talking about this shoulder that may have been injured while on active duty by an injury of some type that causes it to dislocate, okay? If conservative treatment doesn't work for that particular injury, and or they try steroid injections again, less invasive to more invasive, if they try that and that doesn't work either, and this then puts it in a realm of the surgeon. And I remember what that's called. It's called a Bankart's injury or some of that nature. I may try to look it up and add it to the video in the long run so that that specific injury can be found. But again, if you sustain an injury of your shoulder while on active duty or while in service, that causes a dislocation of the shoulder, conservative treatment doesn't work, which may include physical therapy. And in physical therapy, the course of action that they're taking is they're trying to strengthen the ligaments that hold the shoulder in place around that injury to again tighten up enough to stop that shoulder from dislocating, okay? So that may be the first course. It will be less invasive to more invasive. If that does not work, and the soldier may start or continue to have dislocating of that shoulder, where the shoulder may be dislocated while they're doing a push-up, Okay, in the military, we do push-ups. If they're doing a push-up or doing pull-ups or doing whatever physical performance test they may be doing, and that shoulder gets dislocated or continue to be dislocated, and it's not resolved by conservative care, which could include physical therapy, and surgery is decided. Again, we're back to surgery. And remember, that's the issue I was trying to hit, as well as some of the others. If surgery is decided to be the course of action taken, once surgery is done, then again, if it's congenital, it takes it beyond the normal course of the disease process of that congenital injury, and service would have aggravated it if you're consistently seen for it. But if surgery is decided for that dislocating shoulder, once surgery is decided, even if it's a congenital abnormality, as I've said before, once surgery is done, it takes it beyond its normal course and should allow for the veteran to file for service connection, okay? And again, once surgery is done, it takes it beyond its normal course, as I've repeated many times. But it's important because this kind of wording is important and needs to be incorporated in whatever filing is done, or it will be incorporated by a provider such as myself, a PA, a doc, orthopedic surgeon, or a nurse practitioner. Nurse practitioners are doing CMP exams too. They do a great job also. I've seen many of their notes. So don't be put off if it's a nurse practitioner or a PA, or you're not seeing a doctor. Most of the times the PAs or nurse practitioners have a lot of experience in the area, and they'll do a fair evaluation to allow appropriate adjudication of the findings for the veteran. But again, don't want to stray. If we're back to that surgery for that dislocated shoulder, then again, it falls within that category where the veteran should be able to file for a service connection for that injury because you've had surgery. And even though it's a congenital abnormality, you've had surgical intervention while on active duty, which should open the door and allow you to file for service connection for that surgery. Now let's move all the way back around on where I started, and we'll close this out with this information, okay? We've gotten by all that other stuff, and you've had surgery for that injury, okay? Any post-surgical complications that a veteran may have of that shoulder after surgery, which could include continued dislocation, continued aggravation, continued pain, unresolved by anything, okay? Those are post-surgical complication or ongoing abnormalities or pain from the shoulder, a status post or after surgery for the shoulder, and the surgery was done to help out whatever condition was found, okay? Any continued problems or new problems that may present after the surgery are considered post-surgical complications, and the veteran can file for that, okay? I hope you understood that. If not, again, play this video again and you'll be able to follow what I said. And I've been redundant and irritatingly so because after talking to multiple veterans, they don't have this knowledge or they don't know how to word it. So I've given you a lot of the wording that would give substance to the filing of, again, this congenital abnormality of the shoulder that was aggravated by whatever job they were doing, that had conservative intervention that didn't work, that had a consult to an orthopod where they seen a nurse practitioner, PA, or surgeon who then may try steroid injections to calm the area down. We use steroid injections because even though there's bone in that shoulder, there's still soft tissue in there that become aggravated, that can become aggravated, and there could be swelling in there that may be causing a problem. So the steroid injection is given to take down any inflammatory processes, okay, that may be going on in the shoulder that may be resolved by that steroid injection to either the glenohumeral joint or the subacromial space of the shoulder. And listen, that's just big provider talk, okay? But if that helps you, add it to that you had subacromial injections or you had glenohumeral injections. So throw those big words in if you can, but just simply putting that you had injections and they didn't work is fine. Wherever the injections may have been for, whatever provider is reviewing your medical records should be able to look in the medical records and find whatever injection may have been given for the shoulder. If a veteran mentions that to me, whether I try to find it through electronic means, which is an electronic search. If a soldier or a veteran or military person, Air Force person, Coast Guard person, if a veteran mentions to me that they have had injections while in service, and I can't find it through electronic search, then no matter how many pages are in there, what I personally do is I'll go page by page. And I'll tell you what, that has ferreted out for me for a lot of veterans. If it's handwritten in the chart, you can't find it electronically. Because whether it's a PDF document or whatever document it's put in, the electronic search is looking for that, where it's mentioned. We don't have electronic search capability that's gonna find written notes in the chart. Thus, I will then go page by page. And I will let you know this, 100% of the time when a veteran has told me they had shots to the shoulder, if I can't find it electronically, once I went page by page, I've been able to find such injections that were handwritten in the chart that you can't find electronically. And unless you get a provider that's going to do that, they're not going to find that, okay? And I've had veterans that have had, man, I think the most pages I've seen is about 5,000-6,000 pages. And yeah, it's tedious, and some people might consider it a headache to go through page by page, but I do it. Especially if the veteran tells me something that I cannot find electronically, then I resort to that. And also, let me do a ding to providers. Providers don't always write in the most beautiful handwritten script. They do not. So again, electronically, you're not going to be able to find it, and you have to look page by page. And even then, if the provider hasn't written it in beautiful script, most providers can make out that handwritten note enough to see what it was that may demonstrate an injection or other consistent or chronic treatment of whatever area you may be discussing. But in this case, again, we're talking about the shoulder. That's a congenital injury that the surgeon, whether active duty surgeons or whether you're consulted out, decided to do surgery, and we moved on to any post-surgical complications. You should be able to file for those also, because it's secondary to the surgery that was done on active duty while you were serving in uniform. So that kind of surgery should open the door to allow for submission and claim, a valid claim for service connection for that injury. Okay, again, listen, I can't give guarantees to any of what I just said, but I will tell you that if the provider that you see, again, whether it's a nurse practitioner, physician assistant, or a MD, I gotta believe they're gonna do the best job for you. They're gonna review those charts. They're gonna do the right thing. I know I do, and I'm gonna pray that all providers are doing it, okay? But again, I can't give any abnormalities for that. But again, not to stray too far. We're talking about, again, the congenital abnormality that existed prior to service that was aggravated by whatever activity during service, whether you're climbing on a truck, fell off a tank, was under a vehicle and something fell on you and hurt that shoulder. That was a congenital abnormality. It was injured while in service again. And if you get to the surgeon, surgery is done, you have post-surgical complications, you can file for those post-surgical complications, and I advise you to file for the surgery itself. And the post-surgical complications secondary to the surgery that was done of that congenital abnormality that existed prior to surgery that was aggravated secondary to service, okay? So we're beyond all that, okay? So we're making a circle around to the scar, okay? One of the most frequent things I'm finding when I'm talking to veterans about service connection, and in this case, we're using the shoulder, which was a congenital abnormality that needed surgery to correct whatever problems you may have been having, okay, around that congenital abnormality that may have been secondary to your service, okay? A lot of times the surgeons can do such surgery, what we call laparoscopically, which means they make small holes, go in with probes, and they're able to do what they need to do through those small holes, okay? But even if they do them through the small holes, usually there's some type of scar there, okay? And again, we're going all the way back around to what I initially started talking about, which was the scars, which are secondary to the surgeries that were done on active duty. If a veteran who has had the surgery laparoscopically, and they might have 2, 3, 4, 5 scars about the shoulder, if they're having problems with those scars, they're tender to touch, they become aggravated by wearing clothing on that, the pressure aggravates those scars, a veteran can can file for service connection for those scars, okay? Which would entail the veteran going through, you can go through e-benefits to file for service connection for those scars if you're having a problem with them, even if they're small laparoscopic scars. If they're causing discomfort by tender palpation, or if they're causing discomfort by clothing you may wear, or if they're causing discomfort by clothing you have to wear, secondary to whatever job you're doing after you leave service, okay? If whatever that equipment is aggravates those scars, you should be able to file for a service connection secondary to that surgery that was done on active duty, okay? So we've covered that. Those are the small scars, which incidentally, it doesn't matter how big they are. If they cause problems such as pain or discomfort, or if they get infected frequently, even if they're small scars, or if they should have seepage of some type, of any kind of fluid or anything, that would be indicative of maybe that scar is infected for whatever reason, okay? Scars can be infected by scratching on them too hard, creating an open sore of some type there, and then some kind of outside pathological organism, or an organism that should be outside the body gets inside. It can cause an infection of that scar, okay? Which you would need to get treatment for with an oral antibiotic. So that's a problem secondary to the scar that was created by the surgery, that was of a congenital abnormality that was in surgery. Please bear with me for being redundant, but I find that veterans, they just really don't know these things. And while I can talk to them directly about this information, I can't have such conversation with them during the CMP examination, because that's not what it's for. I'm not there to treat. I'm not there to create any treatment plans or make any recommendations of treatment. All of those things are beyond the realm of what a provider should be covering while doing a CMP exam. Thus, after having all these experiences with veterans and finding these things out as being a problem, I felt the need to make this video, and that just happens to be a video I'm making this particular week. And every week I'll make a video to try to explain something I may have come in contact with during that week, which again, veteran may have a problem with here or there. And I won't give you any specific information, but talk about the areas in general and that sort of thing. So we'll stay within a realm of HIPAA violations, anything like that, but I can generously talk about a condition in and of itself, because anybody can have it, okay? So please don't fault me for being redundant with what I'm saying, because this kind of information can and will help a veteran in the long run, and allow them to file a claim that can be better understood by the VA, because you're using some buzzwords that they'll know what you mean. But even if you don't know these big provider words, just put what you understand in there. I'm having problems with this shoulder, and I had surgery, and I still have problems with it, okay? That's sufficient, and then it'll go through the process and get to a provider, and it's then you can tell the provider what problems you're having and this, that, and the other, and they can research your records and find the information. And again, I'm gonna pray that they will make sure they put that information in that CMP report. But okay, we're gonna come to a close. Oh man, this has been about 52 minutes I've been talking. It's been a long talk, but I feel that this information is pertinent. But again, we're gonna close it out with hitting the scars on, and again, we're talking about the shoulder, post-surgical complications after you had the surgery on active duty, to fix whatever problem you may have been having with a congenital abnormality. Once the surgery is done, it takes it beyond its normal progress. So we're talking about the scar material, which is the objective of this whole conversation, but we had to get to the scar. If in the case of the shoulder for the surgery, the surgeon says, okay, there's too broad an area or the process is too big for me to do it laparoscopically. That's with making the little holes and going in with the probes and whatnot. It's too big a job to do it that way. And this reflects on the knees or wherever they might do it. If they do a large open incision, okay, with African Americans and sometimes with Caucasian Americans also, but African Americans have a larger proclivity of having keloid formation. And what a keloid is it's that post-surgical scar that can get there that might be gaudy or ugly, whether it's in the shoulder, abdomen, or wherever. We're talking about that scar material, okay? That's what we're talking about, that scar that is aggravated by the large scar, and even if it doesn't matter what size, but I'm talking about the large scar since I've already covered the laparoscopic scars. These are the large scars you may get, whether it's on that shoulder, abdomen, knee, back, wherever. If you have a large scar and it keloids, or even if it doesn't keloid, if it becomes hyperpigmented, which means it's darker, or if it becomes hypopigmented, which means it's lighter than the skin around it. Those are significant findings for which a veteran can file a claim for, especially if they're in an area that's well seen, which can be aggravation in and of itself, such as facial surgery, surgery on the hands, surgery on the knees, areas where this can be seen at. Then that is looked at as an exposed area. If there's a problem with that, even if it's psychological, if you have a big scar on your face and it's psychologically causing a problem for you, okay, then you can file for that, okay? Again, I can't guarantee you any service connections, and I can't guarantee service connection with anything I've discussed, but I want to give you information that will give you a viable course of action you can take that may ferret out the the service connection for whatever we may be talking about, or whatever anatomical location we may be talking about, okay? So we're talking about a large scar that's there secondary to surgery that you had on your shoulder that was of a congenital area that took it beyond its normal course. So we're talking about that scar on the shoulder, and depending on what the surgeon may have to do, if it's a bank arch lesion, which is what I mentioned before, or if it's something going on in the shoulder joint is the glenohumeral joint, okay? If it's something going on in there, which they feel is gonna take a major surgery or may involve a total shoulder replacement. Those are procedures that would call for a larger surgical incision to be made, which can have a potential for the keloiding, which can happen more pronounced in African Americans, but I've seen some Caucasian Americans or Americans or veterans of whatever color. I've seen keloiding in all races, depending on that individual's skin texture and their skin, that individual's reaction to the incision, okay? So it's not just African Americans, but I've seen a higher proclivity for African Americans to get that type of keloid of the shoulder after a large surgery, okay? So you've got a large surgery that was done of that congenital abnormality that is causing problems, whether it's psychological, pain, tender to palpation, or whether clothing wear over it is causing an issue. Then a veteran can file for that post-surgical scar. There's a disability questionnaire that a provider can do specifically to cover that scar area, which will document the length of the scar, the length as well as the width of the scar, as well as if it's tender to palpation or whether it's tender to any pressure put on it, whether it aggravates a veteran in their sleep if they roll over on it or roll over on that shoulder. These are important findings that the provider can document in the veteran's chart, which will and can affect service connection as well as the degree of service connection. Now, I can't sit here and say again that you're going to be service connected, but I can say if you use these things I've talked about on this video, it'll increase your chances of being able to get service connected for whatever scar that you have. And I also can't tell you what degree of service connection you may be given for that area. Okay, I don't control such things, but I can tell you myself, and I'm going to pray that every provider is going to measure it, its length, width, the effect it's having on you, as well as any ongoing problems you may be having post-surgical in whatever DBQ they may do, okay? So again, if you have a scar, I found that most veterans don't even know that they can file for that scar if it's causing problems. Again, doesn't matter if the problem is pain or if it's in an exposed area and it's psychologically affecting the veteran because people are looking at it. It looks weird. That's a negative impact on the veteran. And it's substantial enough, depending on how it impacts the veteran, that they can file for it. Neither I or any provider can tell a veteran, yeah, you have a scar, yeah, it might be painful, or yeah, it might affect you psychologically, but that's not a reason enough to file for it. Nobody should tell you that, because they can't give subjective information on you. They can only document objective information. But you're the only one that can give them subjective information. That's from a point of view of you. This is what I feel. And that's what you should focus on as far as filing for that congenital abnormality that became aggravated by your duty, which got to needing surgery while on active duty or within a year of getting off of active duty, that you're having post-surgical complications of, whether it's of the secondary to the surgery or whether it's secondary to the scar, whether it's large or small, made by laparoscopic scopes of that shoulder. You should file for that if it's causing you problems and issues. And this brings us all the way back around to what I initially started this hour-long conversation about. But again, I felt it was important to cover this issue because I've seen it, and I'm seeing it way too often. And I'm finding it when I'm talking to the veteran about the surgery. And the surgery may be why I'm seeing them, or it may be secondary to something they had done on active duty. One of the things that they should always be asked, especially if it was surgery, and there's a direct question on any DBQ, which asks, has the veteran had surgery for whatever claim they put in? Every provider should see that. Every provider should ask that question. Did you have surgery while you were in for that congenital abnormality or not? It doesn't matter if it's congenital or not. If you had surgery while you're active duty or within a year after you leave active duty for whatever disease process it may have been, whether it's conservative or not, all of that falls within the realm of you being able, or you should be able, to file for service connection for, okay, to my knowledge. Again, that surgery that creates a large scar or a small scar that was done while you're in surgery that you're having post-surgical complications for beyond your time in service, okay? If you're having those problems, then you should file for it. And just let me add this, and I've said it before, but I want to make sure I key in on this. I'm only finding out such things usually when I'm inquiring of the veteran, whether I'm asking that direct question or whether I'm asking a question in reference to that. They'll just mention, yeah, I had surgery on that while I was active duty. For me, I automatically say, Then I can look in the notes and see maybe if they're service connected for a scar. Oh, I asked them, are you service connected for that scar? How long is that scar? Or tell me a little bit about that scar. Because again, if they have a scar secondary to that shoulder, there was a congenital abnormality that while they were in service became aggravated, for which they needed surgery for. This opens up the process of them being able to file for service connection for it. And if I asked about it, and if any provider asked that question, and again, that question is in just about any DBQ disability questionnaire that I've ever done. Has a veteran had surgery for whatever it is I'm looking into? Okay? And if they have had surgery, I will ask them, are you service connected for that? 75 or 80% of the time, they say no. They're not service connected for it. I find that so disappointing because that tells me that whatever provider may have seen them, even if I'm doing a post-service connection eval, which sometimes we do, they didn't ask them that question, and it should have been asked. But in my case, if I ask that question and they give me a yes, whether it's 20 years later, if they still have that scar and they're still having a problem from it, and they say it's painful to touch, it's painful when I wear clothing over it, for me, that's going to trigger me opening that SCAR questionnaire, DBQ, Disability Questionnaire. It's going to keep me to do that. And that's going to add to my time with the veteran. But for me, being a veteran myself, I put an emphasis on making sure I take care of all of these things. Because again, one of the things I'm finding more than anything with veterans that I happen to see is their lack of knowledge of certain things. And of course, they don't know, but if they're not being told by the VA for whatever reason, and I'm not beating up on the VA, I go there. I'm still seen at the VA, and they've done great work for me. So, but they have a lack of knowledge of what's going on with that condition. And again, we're talking about that scar. Once I open that DBQ, then I can record whatever or any other provider opens that. Sorry, the phone's ringing. I got a call from somebody. They're going to have to wait. But once that DBQ is opened, the provider is going to ask you length and whatever. And I'll tell you this, guys. I've been able to do a significant or do a thorough evaluation of patients secondary to scars through telehealth. The way I do it is I ask the veteran to expose, to take pictures of those scars, okay? And I work out a way for them to get that to me, you know, using HIPAA compliance, whether it's through encrypted email or something of that nature. I get them to get the picture to me and I upload it. And the way I'm able to measure that area, which you just might be saying, when Dr. Skillen, PAC, is doing an evaluation of a scar, since he's not there, how is he able to interpret length and width of that particular scar? How is he able to do that? I'll tell you, it's very simple. Most people in general, whether they're veterans or not, have some type of measuring instrument somewhere handy, whether it be their kid's ruler, or whether it be a tape measure, a mechanical tape measure. They have that at home. And if they can sufficiently expose that scar and put such a device next to that scar, looking at it, I can look at the measuring instrument they're holding up against it and get a sufficient measurement of length and width to do a sufficient evaluation and documentation of that scar, okay? Because that's the only thing that's missing if I'm doing it telehealth, is that I'm not there and I can't put my hands on the patient. But in reality, all I need to do is be able to measure it and get them to put a measuring device, whether it's centimeters, millimeters, inches, or whatever it might be. Whatever they can use, I can convert that to centimeters and get an accurate measurement because they've put the measuring device in close enough proximity to the scar to allow me to get adequate measurement. And from that, and taking input from the veteran, I'm able to document and submit a thorough evaluation of that scar, which may allow the veteran to get service connection for that scar because it's continued to cause a problem. And I'm gonna close this up, okay? One more time, bear with me. The veteran has that scar that was caused secondary to the congenital abnormality that was aggravated, congenital abnormality that existed per the medical literature to be a congenital abnormality prior to their time in service. Congenital means born with it. So they had an abnormality that was there when they were born that had nothing to do with the military, that if they didn't go into the military, it still would have been there. It just may not have caused problems because they might not have in civilian life been doing the things that they were doing in the military that aggravated it. So again, we're talking about a congenital abnormality that caused problems for them while they were in the military, for which they were sent on sick call to a troop medical clinic or a battalion aid station or wherever they were sent consistently enough where more than twice generally will get them a consult to orthopedics. If they were then sent to orthopedics, again, for this congenital abnormality that existed before their time in service, that was aggravated by their duty or while in service, okay? And we're gonna go all the way through. I'm not gonna do the specifics because you can rewind and see the specifics and it allowed me to not continue to repeat the information, but I am gonna repeat it this one more time. So that veteran gets consulted to orthopedics where they evaluated by a active duty surgeon, whether it's a Army, Navy, Air Force, and if they're Marines, it's going to be a Navy surgeon, Coast Guard surgeon, whatever kind of surgeon or orthopedic surgeon it may be. If they evaluate them and they offer the veteran surgery to resolve whatever complaint they're having. Remember, it's congenital, but even though it's congenital, it's been aggravated by service. And if the orthopod or orthopedic surgeon determines after failing conservative treatment and maybe shoulder injections that none of those treatment worked, so they're recommending surgical intervention, okay? Once they do surgical intervention of that area, even though it existed, it was a congenital abnormality that existed prior to service. Once they do surgery on it, the surgeon itself takes it beyond its normal course of progression, okay? And again, I've seen where the VA has ruled in favor of veterans on multiple occasions. You can look it up on the internet yourself. Just look for service connection for congenital abnormality by the VA. They got the stuff on the internet. You can find it. And if you find it, and this is your case, then you've got something you can submit to support your claim. And what that is prior precedence. And in legal terms, that means that this is a decision that's already been made by the VA for whatever you're complaining about. And again, we're talking about a congenital abnormality that was taken beyond its normal course by surgery to that area or chronic treatment of the area while in service. Okay, so we move beyond that. We're over to where you've had surgery on that congenital abnormality. Once you have surgery, again, all that stuff falls into place, but it also creates an area where you might have post-surgical complications, whatever that may be. If it's the shoulder, which we're talking about, you might have continuous pain or continuous dislocation, or the surgery may not have fit the dislocation, okay? And you're having an ongoing problem with that. Even though it's a congenital abnormality, the surgery took it beyond its normal course, and you should be able to, and you should, as a veteran, file for that. And if you're told it was a congenital abnormality, though you can't file for it, which is 95% of what I'm hearing from veterans when I talk to them, even by CMP exam, and I'll be asking them that question about surgery, and they'll say, yeah, I had surgery, I got a big scar. They don't know that they should file for that. And that's the reason behind this long-winded video I'm making here, because it's important. And I want veterans to know, okay? And because I can't talk to them about this during the CMP exam, this creates a forum where I can discuss it. And again, okay, we moved all the way to post-surgical complications after their time in the military, okay? So if you had knee surgery to correct a meniscal tear, or if you had knee surgery to correct a fracture of the cartilage in a knee, which is called a chondroplasty, anything like that, and you're having post-surgical pain or pain in it long-term, you can file for these things. And if they say that it's a congenital abnormality, again, take a minute, get on the internet and look at VA's decision on congenital abnormalities that had surgery while on active duty. That might be long to type in, but those are the things I use when I'm doing my own research for veterans. I type in stuff like that, general terms. And 9 times out of 10, I find it, or find a link that gets me to it, or I can find something in the National Institute of Health library database, or I can find something documented by the CDC. And I recommend that veterans use mainstream information, okay? When you find those, quack documents that doesn't have adequate research or things like that, or it's not by a significant organization like the National Institute of Health or CDC or American Association of Orthopedic Surgeons, that's another good place to find information. If you find information there, that may help you with your claim, okay? So, to wrap that up, if you have surgery on a congenital abnormality while on active duty or within a year of leaving active duty, then you, by my experience and by what I found as far as the VA's decision, can claim service connection for that area. Can't promise you that you'll get service connected. Can't promise you that you'll get 100%. I can't promise you any percent. But what I can promise you is if I'm the provider, and if most other providers, I'm not even knocking them. If most other providers get that kind of information, they'll dig in and find that information. I don't know how many will go page per page, but if a veteran tells me that there's information in there and I can't find it by electronic search, then I go page for page, even if it's 3,500, 500 pages. I look through all their service treatment records, and again, I've been able to find a lot of that material that's handwritten in the charts. If you're a Vietnam veteran, if you're somebody from way back before we really had computers, it's going to be handwritten. So they're not going to find it electronically. So mention that to them. Hey, look, I was in years ago. You might find it if you go page for page. It might jar in them to do that. But again, I do it. And I do it for the benefit of the veterans, in part because I'm a veteran and in part because I got a soft spot in my heart for taking care of veterans. And I enjoy doing this, okay? Every day I get to talk to a veteran, it's a wonderful day for me, okay? As well as a wonderful day to meet their families. And I take all that input while I'm doing a DBQ, even if it's telehealth, which is all I'm doing now that we have the coronavirus out there, which is the safest method for the surgeons. For the veterans. They don't have to leave their homes. Okay, so with that being said, okay, to all veterans, if there are questions I can answer for you, look through you can reach me through the email address I'll attach to this video, and just shoot me an email, okay? It doesn't matter if you're a veteran, if you're a family member of a veteran, shoot it to me, and I'll look it up for you and send it right back to you. Give me about a week, maybe 2 weeks though, to look it up, because I might be overloaded, and if I'm doing CMP exams every day, then I only have time to do that on the weekend. But it will be done, and I will get the information back to you. I'm fortunate I have other people involved with me in my own clinic, the Physician Associate Interdisciplinary Clinic, that can work with me and help me take care of some of this information. And if need be, if I need to look at your records, you can, if you're in Tennessee and Memphis, you can bring them to me. Well, no, can't do that. Coronavirus. I'm in high risk, and a veteran may be too. So we'll figure out a way for me to look at your records. Just reach out to me and contact me. I'll answer all the information I can and be helpful in whatever way I can. Guys, now I'll close this out. It's been 1 hour and 16 minutes, but I created this video because I think this information is important, and veterans need to know it, or they need to have a resource they can reach out to, maybe outside the VA. And like I said, my clinic, for which I'm doing teaching in, which kind of falls in line with what I just did. This is the way I give classes so that everybody can understand what I'm saying. But in my clinic, if you reach out to me in my clinic on social media, and just type in my name, Maurice Skillern, you'll find me. Just shoot me an email and I'll answer whatever questions I can, okay? And if need be, like I mentioned in my first video, if you get letter or whatnot from the VA or from one of the companies that have the contract to do CMP exams, and you're in Tennessee and you want me to do your CMP exam, just tell them my name. They'll be able to find me in their database, and they can set you up to see me, okay? And I promise I'll give you the utmost focus on taking care of your business as if I was taking care of mine. Wasn't meant to be advertisement, but it kind of sounded that way. But I can only give you what I'll do in my clinic and what my people will do in my clinic. So that will give you another avenue. And again, if I can help you in any way, just reach out to me. Okay, until next week, I'm going to sign off here, and I'll make a video next week covering another issue. Maybe it won't be this long, or maybe it will be. If it's an issue I think I need to cover with the specificity that I covered this issue with. So also look up my, what is the YouTube channel for Physician Associate Interdisciplinary Clinic. That's where these videos will be posted, as well as on my web Facebook page for the clinic, as well as on my personal professional Facebook page. I'll be able to answer you through that modem if that's the only way you can reach me. The email address is there, or you can send me Messenger. Okay, but again, give me 1 to 2 weeks, because I've had a lot of veterans start reaching out to me, which I don't mind. The work is not hard for me, and I can do it from a capacity that won't aggravate my service-connected disabilities. Sometimes it's in clinic here for me, or if I'm having an exacerbation of something that may be going on with me, then I can still do research from home, okay? Using my home Wi-Fi. Okay? And I can send you answers to questions or links to articles and that sort of thing. I actually enjoy the research. If it's something new I haven't taken care of, it allows me to become versed on whatever I may be researching. And so it's beneficial to me also. So again, finally, and this is the finally. I know from the first video, finally meant I talk longer, but in this one, finally is what it means. I'm going to sign off here. And listen, I'm praying for everybody. If you're a veteran that's in the high-risk category, please stay in. If you're a veteran that's a senior, please stay in. We know that those areas are high risk for if they catch or are exposed to the coronavirus, okay? So to avoid having a negative interaction with it, because we're having a problem with it now, it's growing again here in the United States, stay in as much as possible. And just to throw some out at you, listen, I know that Walmart, they deliver groceries. So I've used that myself at home. So that's a way to get groceries if you don't want to leave home. So just schedule it through them or whatever mechanism you can use. But stay in as much as possible, okay? And be careful, be safe, and be well. And I'll talk to you guys next week. Take care.